Okay.
Sorry, ma'am, there is a small issue. Now, yeah, now it is live. Suman, you can take things forward.
Monica, it is live now.
Good evening, Madam and delegates. I welcome you all on behalf of Shield Healthcare. I'm Dr. Monica, Medical Advisor. So before starting the session, I wanted to give a brief introduction regarding Shield Connect page. This is an informative blog where we get all the gynec and OBG blogs and okay, I'm sorry. Is my screen visible?
Yes.
Yes. This is an informative page where we share blogs, information regarding blogs, which is related to gynecology and obstetrics, and the webinars, upcoming webinars, whatever these are planned. And the leaders, these are the doctors from all over the India, and the information is in this page, and the newsletters and what are the awareness programs we have. And today's topic is dysmenorrhea, hosted by Dr. Nivedita Datta, MBBS, DGO, DNB, Consultant, Gynecology and Obstetric, President, Bokaro Obstetrics and Gynecology Society, East Zone Coordinator, Safe Motherhood Committee, Manyata Coordinator, Jharkhand, Palliative Care Specialist, Secretary of NGO Courses, Rural Based Center, providing holistic care. And I hand over the session to you, ma'am.
Thank you, Dr. Monica. And could I please start sharing my screen? You will have to switch off your screen sharing.
Yes.
A very good evening to all those who have logged in today to hear about something as banal and as common as dysmenorrhea. Now, you'll wonder why we are having a talk on something called like dysmenorrhea. I think you will have to stop screen sharing. Somebody's screen sharing still. Hello?
Yes, madam, your screen is visible, ma'am.
Okay. I think I'll have to ask the most common question. I think that does the rounds in the Zoom platform. That is my screen visible and am I audible?
Ma'am, just one thing. Can you please unshare and read? Yeah, now it is okay. Go to full screen. Perfect. It's perfect. Yeah. Thank you.
Okay. And I welcome all the delegates who have assembled here today, in spite of the innumerable webinars which do the rounds, to hear something on something which is very simple, yet very discerning, and something which is very disturbing, which is dysmenorrhea. So what exactly is dysmenorrhea? The word dys actually means something which gives discomfort, and menorrhea means menses. So dysmenorrhea, now if you can understand, is basically painful menstrual cramps. And it usually refers to a pain during menstruation, which is severe enough to prevent daily activities or the need for medications. So if you have something like, oh, slight pain, not very uncomfortable, then don't put it under the dysmenorrhea. Don't give the term dysmenorrhea for that. Dysmenorrhea is most common gynecological problem in the adolescent age group, though it also occurs in the other phases of reproductive age group, but in the adolescents, it is the most common menstrual problem. Now, it usually occurs shortly after the menarche. If you know, the first few cycles are usually anovulatory, and dysmenorrhea does not occur in those cycles. So by 6 to 24 months after menarche, the cycles which are there may have pain, may be painful. Now, the classical pain of dysmenorrhea starts from lower abdomen. It is from the low back, radiates to the lower abdomen and goes down to, and then radiates to the thighs. So the girl complains that it starts from the back, comes to the lower abdomen just above the symphysis pubis, and then goes down. The pain pattern is as such. It may start either just before menstruations. She'll say 1 to 2 days before the periods, I get the pain. And the pain is most severe during the first or the second days. And then she will say that as soon as the flow becomes proper, the pain becomes less. But sometimes the pain may continue throughout the cycle. Then there are a few additional symptoms. Pain is one symptom, but then you will get some other symptoms. What are the other symptoms? You will get some GI symptoms like nausea, vomiting. This could be due to the pain itself. It could be due to other causes. Then again, it's either diarrhea or constipation. And this diarrhea is a diarrhea which does not need antibiotics. Then there may be headache and dizziness. There could be fatigue or tiredness, loss of sleep because of the constant nagging pain or the discomfort. Then she might also say that I have a very bloated feeling. I feel full. There's a loss of appetite. I don't feel like eating. I'm constantly full. Then there may be some breast tenderness or mastalgia. And there may be also mood changes like anxiety, irritation, depression. And then, of course, sometimes they may even have loss of libido. And here you would ask that is coitus allowed during menstrual cycle? If you're married and if that you can have coitus, then coitus is not contraindicated during menstrual cycle. But there may be a loss of libido. And it also may be a clumsy phenomenon. Now, why are we so concerned about dysmenorrhea? Does it really have any effect on anyone except the adolescent? Yes. For the adolescent or for the woman who's suffering from dysmenorrhea, it may lead to absenteeism at school as well as work absenteeism. So what does that mean? Now that means if a woman is not working 1 to 2 working days every month, it is a loss of approximately 600 million working hours globally. So then this affects the quality of life and performance also in the daily life activities of women, because there may be decreased work efficiency, or for the girl child, decreased focus on studies, reduced sleep quality, physical activity, poor mood, anxiety, and stress. And then they say there is a huge financial loss. If you measure working hours in terms of money, there's a huge financial loss for the nation. The prevalence is estimates between 45 to 95% of the menstruating women. So you see, it's a huge amount. The prevalence is really huge. So when they say that, okay, that means dysmenorrhea is something wrong with me, you can say it is one of the commonest problems. So there may not be anything wrong with you, but yes, if it's troublesome, it needs to be corrected. Severe dysmenorrhea may affect 25% of the women. Now, dysmenorrhea, we know, are mainly of two types. One is a primary dysmenorrhea, and the next is a secondary dysmenorrhea. What is the difference? A primary dysmenorrhea is without any pathological causes. That means there is menstrual cramp, which is painful, but there is no disorder. There is no problem in the reproductive tract which can cause this pain. A secondary dysmenorrhea is due to a reproductive tract disorder or a pathological causes. And the causes may be many, which will be enumerated later. So how to differentiate between the two? One is by a medical history, and then two is definitely by an examination. So the medical history, the history of primary, let's see about primary dysmenorrhea, what will you get? You will see that the menstruation occurs with cramps in the lower abdomen. The onset is 6 to 24 hours after menarche, and there's a very predictable pattern. The pain decreases as soon as the flow improves and may be accompanied by some systemic symptoms, as I've already mentioned. Physical examinations and ultrasonography really reveal no pathology, and that is the primary dysmenorrhea. Now, in a secondary dysmenorrhea, you will definitely get a pathology, plus the pain is different. So, before I can, let me go back. The pain onset is usually greater than 2 years after menarche. The menstrual cycles may or may not be regular. The pain is even during the non-menstrual phase of the menstrual cycle. The woman will complain that the pain starts before the period starts, actually continues throughout the menstrual cycle, and may even continue for 1 or 2 days after the menstruation stops. Then they have other symptoms like of abnormal uterine bleeding, like menorrhagia or intramenstrual bleeding. Then there is a definite pelvic pathology, which is either evident by a physical examination or by an ultrasonography. So let's come up to the first, let's discuss primary dysmenorrhea, because this is something which is very common. And this is the complaint which with most girls come to us or their mothers will bring to us. The exact cause obviously is not completely understood. However, there are 3 things which are most important. And out of the 3, the most important thing is a prostaglandin. The other 2 are a forceful uterine contractility. And the next is a decrease in the uterine blood supply. Again, this could be due to prostaglandins. So for the uninitiated, we all know that prostaglandins are lipid compounds which are present in the cell membranes. Now, there has been found to be an increased prostaglandin concentration just before menstruation. What does prostaglandin do? 1, it causes a forceful contraction of the uterus. It narrows the blood vessels, that is, it causes vasospasm. And that vasospasm leads to ischemia of the uterus. Then again, prostaglandins increase the sensitivity of the nerve endings. And all these, as you can see, all these contribute to the concept of pain. So, how will you now find out? You can take a proper history, a detailed history if you have the time. And if not, please ask one of your nurses to do so. There are a lot of questions. If you come to the menstrual dysmenorrhea history, there is a lot of questions. You can download it from the net, which says that I feel irritable, I feel depressed, I have abdominal pain, 1 day before my periods, I feel exhausted, lethargic. And then there are various columns which says never, rarely, then there can be sometimes, often, and always. And you have to plot it accordingly, the various problems, and then score her on the pain scale. The pain scale comes from 0 to 10. 0 obviously is no pain, and 10 is the worst imaginable pain. And with this, if you can plot it, and you can see how well she is responding to whichever medications that you are giving. So now we come to the management of the primary dysmenorrhea. As I said, the causative factor is prostaglandin. So what will be the management? Obviously, antiprostaglandins will be the management. And the best among that are the NSAIDs. NSAIDs could be anyone, right from diclofenac to etodolac, the ibuprofens, the ketoprofens, naproxen, piroxicum. But the most commonly used drug is mefenamic acid. The dose of mefenamic acid, however, is 500 milligrams. It should be given 500 milligrams twice or thrice daily for optimal effect. The second line of drug is if it does not respond to mefenamic acid, or if you feel that the pain has come down but not to that extent, then obviously to make an ovulatory cycle non-ovulatory, the next line of drugs would be an OC pill. Now, obviously, everything has drawbacks. All the medications that we do have side effects and adverse reactions, and NSAIDs and OCPs are not new in that field. There will be GI side effects. There will be allergic reactions. NSAIDs are contraindicated in renal insufficiency, peptic ulcer diseases, GI bleeding, or hypersensitivity. There's an overall failure rate of 20 to 25%. and long-term use is discouraged. However, as when I tell my patients or the mothers of the women who come to me, of the girls who come to me, that if taking 1 or 2 tablets relieves their symptoms, there is no harm in taking that tablet over a period of even 5 to 10 years. And the pain definitely comes down after childbirth. OCPs, we all know, may cause thromboembolism, and estrogen in a very early age does cause early closure of epiphyses and stunts the growth. So obviously, as I said, the first line of drugs will still remain the NSAIDs. However, if you see this chart, you will see that menstrual pain management behaviors may vary, as you can ask any of the adolescent girls coming to your OPD. There are pharmacological methods, but there are also a lot of non-pharmacological methods like hot bath, heating pads, distraction, exercises, then even acupuncture. So a lot of these things may be resolved. If you see a lot of them, like in fact, sometimes you can see even it comes up to 39 to 26%, 39% in mild, may respond to just 39.1%, may respond to just exercises, which is really quite a good amount. So all these should be tried along with your pharmacological supplements. Here is a list of various non-pharmacological approaches. As I said, acupuncture, acupressure, heating pads, even rest or sleep, exercises, medicines, then calcium, vitamin D3 supplementation, sometimes along with decreases the need for analgesics. Then various herbal medications like ginger root, turmeric extract, pineapple extract. Don't ask me the mode of action, but yes, they are effective. Then sometimes they say mint, aloe vera, cinnamon. All these, along with a balanced diet, may go a long way in relieving the pain due to dysmenorrhea. And there is no harm in trying the home remedies. If they respond to home remedies, good. If not, there's always NSAIDs and finally OCPs in our armamentarium. Next, we come to something which is discomforting for the gynecologist, and that is secondary dysmenorrhea, because basically it is due to an underlying disease of pelvic organs. What happens is that sometimes we tend to treat most dysmenorrheas as primary dysmenorrheas, and we might tell the mother of the adolescent girl or the adolescent girl herself that no, this is a primary dysmenorrhea, and it'll go back, it'll become okay after you get married and have kids. So there's nothing to worry about. You just keep taking NSAIDs. And then later she comes back to you about 6-7 years later with infertility, and you find large endometriomas. So you should be very clear about whether it is a primary dysmenorrhea or a secondary dysmenorrhea right from the word go. And this is something which can make a hell of a difference in the later outcome, because she should not come and blame you 7 years down the line saying, I'd come to you and you had said it was primary dysmenorrhea and you did nothing and now have huge endometriomas. So what are the various causes of secondary dysmenorrhea? As I said, they could be reproductive tract problems or even pelvic problems, endometriosis, congenital anatomic abnormalities. Like if you have rudimentary horn which is not connecting, to the main cavity, then every time there is a menses, then that bleeds, but it cannot come out, so it is painful. Sexually transmitted infections or PIDs, adenomyosis, uterine leiomyomas or fibroids, and even cervical stenosis, when obviously cervicals, not only just cervical stenosis, but cervical stenosis, cervical atresia, which can lead to hematometra and painful menses. Then there are non-gynecological causes, which like high-tone pelvic floor dysfunction, irritable bowel syndrome. Now, it's very important to differentiate this. Bladder pain syndrome. You will find a lot of girls have, a lot of women with secondary dysmenorrhea are actually bladder pain syndrome, the inflammatory bowel syndrome, which is there. So it's very important to differentiate inflammatory bowel syndrome from secondary dysmenorrhea. Then, of course, pelvic adhesions and inflammatory bowel disease. So how can you, how can you diagnose secondary dysmenorrhea? One is by history. The onset of symptoms is several years after menarche. Then you might have a history of pelvic infections, vaginal discharge, that is PID, history of IUCD insertions, pelvic surgeries, which may cause pelvic adhesions, then abnormal uterine bleeding. So you think of adenomyosis, polyps, fibroids, infertility, and dyspareunia. A physical examination, especially examination of the breast, abdominal examination, a pelvic examination, a papa speculum examination is mandatory. Then investigations. Besides the ultrasonography that we do routinely, remember to think of a CBC, exclude anemia, infections, high vaginal swabs. Laparoscopy may be required if you think of endometriosis or pelvic adhesions. And a hysteroscopy if polyps are intrauterine pathologies are like, as I said, polyps or even cervical stenosis is suspected. Then you might even think of a hysteroscope, which is while that is difficult to maneuver a hysteroscope. This is the chart which gives a differentiation of primary and secondary dysmenorrhea. I've already gone through most of the points in details. Just to recapitulate, you see the onset, it's different. Primary starts shortly after menarche, and this will take after 2 to 3 years. The timing is different. This is usually during menses or just before menses and lasts for 1 or 2 days. And this starts before the menses, continues throughout, and after the menses. The age will be different. Duration I've mentioned. The symptoms are associated symptoms of dyspareunia, menorrhagia is there in secondary dysmenorrhea, which will not be there in primary dysmenorrhea. Then obviously the nature of the pain is different. The way the pain originates in the primary dysmenorrhea, lower back, front of the lower abdomen, and then thighs. Here, it may vary from pelvic because of the pelvic pathology, the intensity of the pain and the nature of the pain may be different. Primary dysmenorrhea usually improves over time, whereas secondary dysmenorrhea worsens with time. And there is no improvement with sexual activity or deliveries. And of course, then you have an internal examination to exclude any pelvic pathology. So this is where the most important aspects of the differentiating factors of primary and secondary dysmenorrhea is there. And it is very important for those assembled here to be able to differentiate the two. And this is why I'm taking, today we are all here together to discuss the two types of dysmenorrhea. The main purpose is not to make you aware that dysmenorrhea exists and its prevalence, but to make you aware of the fact that dysmenorrhea is disconcerting for the woman or the girl concerned. It's imperative to at least elevate her symptoms because it leads to absenteeism and in both school and working hours. Then secondly is that you have to be able to differentiate the two types of dysmenorrhea and manage accordingly. In secondary dysmenorrhea, we all know the management is with NSAIDs, as well as treating the pathology which exists. Because just giving NSAIDs is not going to improve the pathology. So you have to combat the pathology whichever exists. Lastly, dysmenorrhea should not be confused with premenstrual syndrome, which presents, as you know, with similar symptoms, which I had said, nausea, vomiting, bloated feeling, mood disturbances. So because how can you differentiate? A premenstrual syndrome occurs much before the menses begin, and as soon as the period starts, the syndrome stops. The symptoms resolve, unlike dysmenorrhea, where the symptoms may continue for 72 hours. Just a short note about premenstrual syndrome before I end. And this is because PMS is something also which is very common and very disturbing for the woman. It's slightly different from what I have to teach, from what I have to talk about today. But because you have to differentiate it, I'm just informing you that it's a group of physical, emotional, and behavioral symptoms that occur in the second phase of the luteal phase. And this too interferes with work and day-to-day activities. The symptoms, if you see, are more or less the same as primary dysmenorrhea. And what causes this is again not known, but various hormonal interactions. They say progesterone, B12, B6 deficiency, and sometimes even psychological problems. So any drugs that inhibit ovulations relieve the PMS symptoms. And what is very important is counseling, reassurance, lifestyle modification, exercise. Nowadays, I don't. There's a lot of stress on exercise, probably because we are becoming lazy, and that is why a lot of problems are occurring. So 20 to 30 minutes of regular exercises every day releases the endorphins, which can be pretty beneficial for PMS. And then, of course, we have the treatments like antiprostaglandins for the cramp pains. Then we have drugs like OCP, danazol, medroxyprogesterone acetate, evening primrose oil. If there are a lot of edema and mood irritations, then even diuretics, because it decreases the cerebral edema. For breast tenderness and for any breast discharge, then we can give bromocriptine. So there, vitamin B6 is a wonderful drug in this. So there are a lot of medications for premenstrual syndromes. I'm not going into the detail of that. What today is my major talk was basically, if you suspect dysmenorrhea, again, I come back to the same thing, differentiate between primary and secondary, manage both, definitely counsel the girl that though dysmenorrhea is discerning, primary dysmenorrhea is not pathological and may resolve. So do not worry about the pathologies, but yes, take medications so that your absenteeism is not there and you can continue your normal quality of life. Thank you. I think that is where I end with my talk. It's a big thank you to you all too for not only logging in today, but a big thank you from all the girls and all the women whose life you will make worthwhile if you can treat dysmenorrhea properly. Here, I'd like to hand it over back to Dr. Monica, because obviously, since we are talking about dysmenorrhea and we have already spoken about various non-pharmacological preparations, Dr. Monica will just give a brief a brief idea about a product which is in the market for dysmenorrhea, which is non-pharmacological. Over to you, Dr. Monica.
Thank you, ma'am. So we have recently launched a product which is a nutraceutical, which is a nutraceutical product for primary dysmenorrhea, which constitutes of bromelain, which is a pineapple extract, and fencon, which is a fennel extract.
I think there is some technical issue. Yeah, ma'am, I'll continue the.
Am I audible? Am I audible?
Yeah,
yeah, you're audible, but please be loud. Yeah. And do you have any PPTs for the same so that you can share that?
And yes, ma'am. Yes, ma'am.
Dr. Monica, you can share the screen about that four key ingredients what we are actually offering in Dysmenorrhea. Meanwhile, I'll just share some of points to Dr. Nivedita and the delegates who actually joined. Ma'am, as you rightly said, we have launched this product, ma'am, that is Dysmenorrhea. So, as you rightly said, it's a product which is actually offering pain relief without any side effects. And this is a product which is made up of bromelain, curcumin, fencon, and ursolic acid. It's a combination of these four ingredients, and which are actually active constituents from plants without any side effects. And we had done an Indian clinical study. And in that Indian clinical study, it was evident that the product actually showing positive results for treating the dysmenorrhea condition. And as I said, it is a non-NSAID, madam, without any side effects, so that people can take the drug without any side effects and without any complications. So that is what the benefit we are offering. So Dysmenorrhea is nothing but a drug of choice, which is safe for treating dysmenorrhea, which has antispasmodic action and anti-inflammatory along with analgesic action. And the onset of action is also starts on an average 30 to 34 minutes. And severe of pain also will be relieved. We actually measured it on NRS scale, and according to that scale, the pain relief was also achieved very well with this product, ma'am. And one great thing about this is it's absolutely safe without any side effects. Yeah, Monica, you can continue. Please continue, Monica.
Is my screen visible, Surya?
Yes, yes.
Uh, so the description
No,
which
Dr.
was
Monica,
given
your
by
screen is not
Surya
visible. Your
regarding
screen is not visible. I think in the meantime, I can take the questions if there are any in the chat box.
Yes, ma'am. Yes, ma'am.
And
Just
then-
we are checking it. Yeah. There is one query. So, how do you recommend? Treating dysmenorrhea without NSAIDs?
Okay. See, as I said, there are pharmacological and non-pharmacological managements for dysmenorrhea, for primary dysmenorrhea. And if you don't want to use NSAIDs, then you can go in for whatever the non-pharmacological preparations are there. Hot pads, heating pads, acupressure, acupuncture, even sometimes rest. Rolled up in bed, like when you have colicky pains, how do you tend to roll up in the colicky position? That you can use some counteractive, like we have these counter irritants. So you use some counter irritants on your back, that can be helpful. Then hot water baths, especially they used to say soaking your hips in hot water. I mean, of course, it will make it slightly bloody, but then whatever it is, soaking your hips in hips and buttocks in hot water, warm water, that helps. Then there are a lot of herbal preparations, a lot of Ayurvedic preparations. Don't ask me how it helps, but they do help. They say these ashok, the bark of an ashok tree is beneficial. Shatavari and all, they're beneficial. They tone up the uterine muscles, and hence there are a lot of products which come out with that, which they say tones up the uterus so as to prevent dysmenorrhea. Frankly speaking, I have very little experience about them for dysmenorrhea, because as a allopathic doctor, so I usually prefer writing allopathy medicines unless I'm like 100% sure that, okay, this is going to be effective. But I usually don't go in for mixopathy. Then this is there. And then regular exercises. I found if you go in for yoga, regular yoga or exercises, then the severity of dysmenorrhea decreases. So your need for analgesics might decrease. Then of course, if after that also you have dysmenorrhea, if somebody has dysmenorrhea, then NSAIDs are definitely going to be there.
Yes.
There are no alternatives to that.
Yeah. Ma'am, another query. Another query is there. So like youngsters are there who are hardly of age 16, 18, 20 years. So what is the impact of using this NSAIDs throughout, like from the onset of this pain, dysmenorrhea pain? So they have to take it every month. So what is that impact, the side effects of these NSAIDs in these conditions for these youngsters?
Right. See, as I said, NSAIDs do have their own side effects. But if it's only primary dysmenorrhea and you have to take NSAIDs for like say 2 days, even twice daily, and if you don't have any don't have any contraindicating features like peptic ulcer diseases or renal diseases, then the long-term effect is not there, because NSAIDs are dangerous if taken continuously for a long time, like especially for like you have it for chronic pains, chronic like rheumatoid arthritis or osteoarthritis. When you take it for chronic pelvic pain, if you're taking for the chronic effect, then they can be deleterious to the renal function. But otherwise, for taken for 2 days a month and say 2 days a month for 12 months a year, and for 5 years, 4 years or 5 years, may not be really deleterious to your renal system or cause gastritis to that extent. All analgesics we know should be taken after meals. You do not take analgesics on an empty stomach to irritate the stomach. So this is something which is very important, that, and you should not have a concomitant peptic ulcer disease. If the girl has gastritis, then obviously you cannot prescribe NSAIDs. Then the only thing you can prescribe is acetaminophen, that is paracetamol.
Yes, ma'am. Thank you, ma'am. Thank you for
And
your
then, of course, now your drug is coming out in the market. Frankly speaking, I haven't tried it as yet. But then, since it's absolutely herbal based and it should not have any side effects on the GI system. So, if only after we put in through a proper trial, maybe we can say that, and if we see the efficacies, then maybe we can all start trying it.
Yes, ma'am. Thank you, ma'am. Thank you so much. So, to further elaborate about our product, ma'am, am I audible and clear?
Yeah, you're audible, but could you please be slightly louder?
Yes, ma'am. Yes, ma'am. To further elaborate about our product, it is actually not herbal or Ayurvedic formulation, ma'am. It's a active pharmaceutical ingredients. 4 active pharmaceutical ingredients have been extracted from plants and made into phytopharmaceutical drug. It is absolutely safe, and we had done an Indian study which was actually tried on Indian patients, and the results were positive, ma'am. And as you said, once you try it, you definitely will agree to our point what actually I was talking about. And this is the formulation, ma'am. You can see this. So my screen is visible, right? Monica, my screen is visible, right? Yeah. Can you please confirm if
So yeah, it's
Yes, yes.
ma'am, what I was actually talking about is this one, ma'am. So for dysmenorrhea with pain abdomen, we are launching first time in India, Dysmenorrhea, ma'am. It's a combination of ursolic acid, bromelain, phenytoin, and curcumin that reduce pain and spasm. And we say it's actually powerful like NSAID because we had done the trial. I mean, Indian trials were there supporting this statement, and it is absolutely safe. And the dose is also like 1 tablet BID, ma'am. And this is how actually our pack looks. So this is about the brief of the product, and our people will come and meet you in very short time, and they will further give you further details about the product, ma'am. And about this individual ingredient, how they actually work in dysmenorrhea. So to give a brief, ursolic acid, it has anti-inflammatory activity, ma'am, and of course as well as analgesic action. And bromelain also same, it provides anti-inflammatory analgesic action. And for phenytoin, they are actually acting as an antispasmodic agents, ma'am. So this is about our product, ma'am. And thank you so much for your time, ma'am, for delivering a wonderful delivery today evening. Wonderful talk about dysmenorrhea. And really,
I would like to point out that I've got a lot of messages saying that they could not join.
Yeah, this actually is there is some technical issue, ma'am. It was sorted and taken, and now it is actually working. So it was in the beginning, there was a technical issue. Yeah, that was sorted in 10 minutes. Yeah.
Okay.
Yeah. And really, thank you very much, ma'am. There is a small technical issue. That is the only thing. Otherwise, it was a really good session. Thank you so much for your time today evening. And tomorrow or day after, our RBM will meet you, ma'am, and to discuss further about the product.
Thank you. Thanks a lot, Abhi.
Thank you, ma'am. Thank you so much. So I'm closing the session now. Yeah. You can leave, ma'am. Thank you.
I can leave. I can close
Yeah.
the session. Thank you.
Yes, yes. Thank you.